Next topic we take up is the diabetes, anti-diabetic drug. So, and anti-diabetic. So these are the drugs which are normally used for the disease management of diabetes or diabetes mellitus. Generally, we call it as diabetes mellitus. And the drugs which are used for the disease management are called as anti-diabetic drugs. So diabetes, actually, it is a group of diseases. Diabetes, it is not a single symptom here. So it is a group of diseases. So where you have the results in the differences in the or high blood glucose levels. Okay, diabetes group of diseases, and which results in there is variation in the blood glucose levels, that is increase in the blood glucose level. So these are the blood glucose levels of in a diabetic patient. You can classify normal. This is the chart. Okay, so micro, that is mg per deciliter. Mg per deciliter, that means moles per liter. Moles per liter. You can convert this mg per deciliter, that you can convert into moles per liter. So, and diabetes, we know that it is blood glucose level, variations on the blood glucose levels. So that is generally diabetes mellitus. It is the increase in the blood glucose levels or plasma levels of glucose, and then normal glucose levels, that is fasting, and then after eating, okay, and just ate, and after 3 hours of eating. So if we consider the fasting levels, when we consider the fasting levels, normal it will be between the 80 mg to 100 mg per deciliter, and that is normal person. And pre-diabetic, one second, pre-diabetic, and pre-diabetic, it is 101 to 125 mg per deciliter, okay, per deciliter, and that you can convert. Okay, this is when you convert this mg per mil, that is millimole per liter, then it will come to the micrograms per ml. You can convert that millimoles into micrograms per liter. So it comes in the microliter only. Okay, micrograms only it will come. And normal patient, okay, of the diabetes, so it is 100 to 80 to 100. And then next one, pre-diabetic, will be 100 to 125, that is 101 to 125. Fasting levels only we consider. And diabetic patient, so this is 126 plus, above 126, okay, above 125, you can call it as a diabetic. The person is diabetic. This is all levels, sugar levels for fasting levels. So sugar fasting levels, and as you know that after eating or after eating of 3 hours, then there is a shoot up of glucose levels. That, but generally we consider this fasting levels. So the fasting levels will be of normal person, glucose levels will be 80 to 100, and pre-diabetic, that is onset of diabetes, and here 101 to 125 mg per deciliter. Diabetic, you can classify if you have the blood glucose levels, that is 126, above 125. So diabetes, generally it is diabetes mellitus. If you see that it is of you know that we discussed that it is increased glucose levels, and this increased glucose levels, you can say type 1 diabetes, and where we say that insulin dependent diabetes or hyperglycemia. So this is also hyperglycemia only, and type 2 diabetes. So where you have the little produce of insulin, or there is no insulin. Okay, insulin is not produced, type 1 diabetes. And generally this is, we know that it is because of the autoimmune disease, where the beta cells of Langerhans, okay, that is pancreatic cells, will be destroyed because of the autoimmune disease, and there is no production of actually insulin here. So this is insulin dependent, okay, diabetes mellitus, type 1 diabetes. Second one is that type 2 diabetes. So type 2 diabetes, it is non-insulin dependent diabetes mellitus. Okay, and here insulin secretion will be there. Okay, it's not that even the insulin secretion is there, you will have the increased glucose levels. That is because maybe sometimes the cells may become the resistant to the insulin. Okay, so that is type 2 diabetes. Another one is that which is not commonly observed, gestational diabetes, and that you will observe in pregnant women. Okay. pregnant women gestational diabetes. So that is temporary. Okay, diabetes, this gestational diabetes, and again this will go off once the pregnancy is over. So, or sometimes it may be continued also. So then, how with the diabetes mellitus progresses? Okay, how you have the diabetes mellitus, how it progresses, and if you have abnormal sensitivity, insulin sensitivity, then it causes the hyperinsulinemia. Okay, abnormal insulin sensitivity because of the abnormal insulin sensitivity. So whether that is a reduced sensitivity, okay, reduced abnormal insulin is not increased, doesn't, okay, normal sensitivity and hyperinsulin, okay, hyperinsulinemia. And then here, because of that, what happens is there is a central obesity. Central obesity means so deposition of the fat, okay, around your abdomen. Central obesity. Once this fat is big, turns out to be insulin resistance. Okay, if you hyperinsulinemia, insulinemia, and then causes the central obesity. Central obesity here in the sense it is if you have, that is a deposition of fat around your waist, okay, abdomen, that we call it as the central obesity, and this develops into the insulin resistance. So then what happens? You have the weight gain is there, and this also can happen. Okay, so if you have abnormal insulin sensitivity, so central obesity will be there, and once if you have the central obesity, weight gain, you know that weight gain it will happen. And if physical inactivity, if you have physical inactivity, again you will become obese, and then it develops the central obesity, can cause the insulin resistance. Okay, and then you will have the progressive loss of beta cells. Okay, progressive sometimes, and then impaired glucose tolerance sometimes improve, and this for this, okay, can be genetic, mainly genetic factor autoimmune disease, and or it can be high glucose levels or high free fatty acids can cause the progressive loss of beta cells and impaired glucose tolerance. And finally, we'll have the diabetes mellitus. So diabetes mellitus progression, if you see, you have the increased weight gain, and or through the increased weight gain is through the physical inactivity and causes the central obesity, and then finally through genetic factors, okay, or high glucose levels or free fatty acids, you'll have the progressive loss of beta cells, and then finally you will have the diabetes mellitus. So this is how the diabetes progresses. And then what are the causes? Causes for obesity, that is, one is the obesity, as I told you, central obesity. Another one is living a sedentary lifestyle or an increase in age and bad diet. So these are the major causes, and we cannot define, okay, we cannot say in a particular person this is the reason. Okay, in one person it can be maybe a obesity, or maybe it can be maybe because of other reasons, and increase in the age, it can be and bad diet, and almost all we say that the cardiovascular diseases and diabetes mellitus, all these we call it as a lifestyle diseases. So it depends upon the lifestyle also, and sedentary lifestyle means here it is that, okay, physical inactivity you can call it as, and physical inactivity, all these comes. Okay, so if you are when there is no physical activity, all these reasons, if you see that, if you generally we are trying to do whatever the, okay, activities we are trying to do, this, that is, we are doing daily, okay, sitting idle, okay, and then sitting without any physical activity, and no socializing, and watching movie televisions or movies, playing video games, or using a mobile phone computer for much of the day. Okay, so this comes under the sedentary lifestyle, and this can cause the diabetes mellitus. Okay, so then coming to the glucose, that is glucose blood regulation, which are the things that regulate the diabetes mellitus, we know that. Okay, so it is increased levels of blood glucose levels, and then the progression of we know that we have discussed the progression, how diabetes mellitus progresses, and we have seen what are the causes for the diabetes mellitus. Okay, so and next one is that we see the hormones which regulate the glucose metabolism, glucose levels. So these are the two main hormones, peptide hormones you can call them, which regulate the glucose metabolism. So one is insulin, another one is a glucagon. So this is a glucagon. We know that it causes the breakdown of glycogen into glucose when there is a reduced glucose levels. Another one is the insulin. What it does is that if there is an increased glucose levels, and glucose will be converted into glucagon. So if you have blood glucose level rises, and then when there is a rise in the blood glucose levels, then pancreas, that is beta cells, will secrete the insulin. Then insulin will be taken up by liver, and then glucose will be converted into glucagon. And if you have reduced levels of glucose, then you have the glucagon, that is alpha cells will be secreted. Glucagon will be secreted by alpha cells, and then the glucose will be taken up by liver, and then it will be converted into glycogen. So these are the two opposite actions. So one reduces the glucose levels in plasma, another one reduces the that is this one increase the this one reduces, and other one increases the plasma glucose levels. So if there is a rise in, or if there is a fall. Okay, another hormone, thyroid hormone also, we know that it is a hormone. So it acts on each and every cell, and it has various functions. One of the function is that glucose metabolism. It increases the glucose metabolism, and in the mitochondria, that is an increased production. Okay, so also thyroid hormone also, that is a than T3. Okay, and so this T3 triiodothyroxine, okay, thyroxine, here if you see this increases the glucose metabolism, and thereby increases the production of ATP. Okay, this is another. And next one is that glucocorticoids like cortisone, hydrocortisone. These are glucocorticoids. Name itself indicates that. So they also regulate the metabolism. And these two glucocorticoids, if you see that, they increases the glucose metabolism, that is they increase the glucose synthesis either from fats or from gluconeogenesis or from amino acids. They increase the synthesis of glucose. So these are the four hormones generally, okay, so which regulate the glucose metabolism. One is insulin, another one is glucagon, another one is thyroid hormone. So thyroid hormone generally it involves in the basal metabolic rate. Okay, regulates the basal metabolic rate, and here it increases the glucose metabolism to increase the ATP production, that is energy required for us. And then next one is that glucocorticoids are also, this is steroidal hormones, okay, like your cortisone and hydrocortisone. They synthesize the glucose, okay, from you have, that is gluconeogenesis pathway, or fatty acids will be metabolized, and this fatty acid also can be converted into that is glucogen, that is glucose, or amino acids also will be converted into glucose. So this glucocorticoids, they synthesize the glucose. These are the hormones which are generally involved in the regulation of glucose metabolism. But for the treatment of diabetes, okay, for the treatment of diabetes, we may not be targeting these pathways. Okay, so we are targeting mainly these two, okay, or mainly one pathway only, because we know that it is increased levels of glucose. So this pathway will be targeting. Okay, so with these are the hormones which regulate the glucose metabolism. And then what are the complications with the diabetes? So signs and symptoms, you can call it as, okay, so weight loss will be there, because okay, generally there is a weight loss, you will in diabetes mellitus, and because you have the increased loss of glucose will be there, increased loss of glucose will be there, and because you have the higher plasma levels of glucose, and then this plasma will be transported to kidneys, and kidneys excretes the glucose. You have the increased loss, that is weight loss will be there, polyuria, and that is increased urination, okay, and polydipsia, increased thirst, because water reabsorption will be prevented. We know that most of the water reabsorption happens in the nephron. Water reabsorption, it will not be secreted. So, but in case of diabetes, so you will have the polydipsia, and that is polydipsia is because of loss of water through the urination. Increased urination is there means increased water loss, and increased water loss, it causes the thirst, and polyphagia, increased hunger, and anyway that we discussed weight loss, and tiredness, and blurred vision. You have the blurred vision, okay, and that is because glucose will be transported in, okay, and it changes the lens, the shape of the lenses. Blurred vision, and headache, fatigue, and slow healing of cuts, that is, and itchy skin. So these are the signs and symptoms of your diabetes mellitus, diabetes type 2 diabetes or type 1 diabetes. So weight loss, polyuria increase, and polydipsia, polyphagia, weight, tiredness, blurred vision, headache, fatigue, and slow healing of cuts, and skin. So these are the signs and symptoms. Okay. So with this, today's class, and okay, last class we have discussed things, diabetic, that is diabetes, and how you define the diabetic person based on your glucose levels, plasma levels. So then we have seen, we have this the definition, we have seen that is type 1 diabetes and type 2 diabetes, that is the type 3 diabetes, and how the diabetes progresses, and finally how type 2 diabetes you will have, that is we discussed, and causes for the diabetes. One of the major cause for the diabetes, that is especially if you see type 2 diabetes, majorly if you see that is obesity, and the lifestyle, and with the increasing age, and that is the diet what you are following. And then what are the hormones that regulate the glucose levels? That is majorly two hormones we know, that is insulin and glucagon. These are the two hormones which regulate the blood glucose level. Apart from that, thyroid hormone. So this thyroid hormone, it acts with major almost all of the cells, and then it also affects the metabolism of glucose, metabolism of lipids. So that is how it can also regulate the glucose. And next one is that that is steroids, especially glucocorticoids, and that is steroids. They also regulate the glucose metabolism. But majorly now we are concerned with the that is type 2 diabetes, that is insulin regulation. Insulin regulation, that is major, because insulin is majorly involved in the type 2 diabetes. Okay, and then type 2 diabetes, especially if you see, it's you will find the weight loss. Okay. Then because when glucose, in the case of weight loss, if glucose is not involved, glucose not available, because we know that diabetes, glucose will not be available for the cells, and then the cell starts using the fat and all, its energy requirement. Then you will have the weight loss and polyuria. Then you have the increased urination, and polydipsia, increased thirst, because you'll be losing lots of water through the increased urination. You'll feel the increased thirst, and polyphagia, increased hunger. And here also you know that increased hunger in this case, so for the cells there is no availability of glucose, and that then it causes the increased hunger, tiredness. So because energy will not be produced from the glucose, so you'll feel tiredness, blurred vision, and because glucose, increased glucose levels, okay, in the plasma of retina or whatever is, can damage the blood vessels of, okay, and then cause the blurred vision, and insulin one or the other way it is involved in the insulin, one way other way involved in the damage of blood vessels in the eye. So insulin damages the blood vessels in the eye, causes the blurred vision, and then headaches. You have fatigue and slow healing of cuts and itchy skin. And again here, the itchy skin, you know that the neurons which are there in the skin, they'll be damaged, and you'll feel the itchy skin. So these are the some of the symptoms of the type 2 diabetes. And then you can feel where with the type 2 diabetes what you will be observing is that in central nervous system, excessive thirst, excessive hunger, lethargy, stupor, and then you have the blurred vision, smell of acetone, because fats will be the glucose, fatty acids will be metabolized, and then in gastric, that is, you have the nausea, vomiting, abdominal, frequent urination, and glucose in urine, and then hyperventilation, and systemic, you know that it will be weight loss. These are main symptoms. And then coming to the we know that the diabetes is of two types. One is type 2 diabetes and type 1 diabetes. So coming to the type 1 diabetes, later we discuss the type 2 diabetes. Type 1 diabetes we also call as autoimmune type 1. And type 1 diabetes, it is majorly of autoimmune disease type. That means our own body cells will be our own body cells will be considered as antigens, and then antibodies will be produced, and these antibodies remove our own cells from our body. So that's what happens in the autoimmune disease. So our own body cells, our own body molecules, our metabolites will be recognized as antigens, and then they'll be removed from our body through the cytotoxic reactions. And in type 1 diabetes, so we have the autoimmune disease. How it develops means we have a gene, so which this gene represents particularly these proteins, that is hemoleucocyte antigen gene. So this is the gene which is responsible for, that is in chromosome 6 actually, I think, or chromosome 6 will be having a particular gene. This gene is called as a human leukocyte antigen regions. So this is the region of our gene which is responsible for the autoimmune disease, in type 1 diabetes, that is human leukocyte antigen. So this region is present in the chromosome 6. And what it does is that this region develops or process antigen presenting proteins on T cells. Antigen presenting proteins on T cells. Antigen presenting, we actually, what happens is, suppose if you have an antigen like virus as such, it will not go and bind with the antibodies directly, they cannot go and bind with the virus. So this virus has to be processed so that antibodies can recognize the virus as an antigen. So there are certain cells which process the antigens, present them to the T cells. So that's what we call it as a antigen processing. And here, human leukocyte antigen, this is the region in the chromosome, so which causes that is the generation of antigen processing proteins. Antigen presenting proteins are antigen presenting cells. So antigen presenting cells there are different types are there. Macrophages. So macrophages are the one of the antigen presenting cells, and dendrites, and T help, and these are the mainly macrophages and T cells, and can say B cells and dendritic cells. So these cells process the antigens and then present those processed antigens to the T cells. So this is, we call it as a antigen presenting. And this antigen presenting is regulated by particular gene called as human leukocyte antigen region. So these genes are present on chromosome 6. Chromosome 6. So the chromosome 6 will have a regions called as a human leukocyte antigen. This human leukocyte region genes, what they do is that they will have the proteins to process antigen and present them to the T cells. Okay, so this is the function of human leukocyte antigen. Human leukocyte antigen, what it does is that it will develop the cells. Which cells? Antigen presenting cells. Antigen presenting cells, what they do is that they present the antigen to the T cells, and once if they are presented to the T cells, antibodies will be generated, and these antibodies will react with the antigen, and finally they will be removed from the body. So what are the antigen presenting cells? Like you have macrophages, and then you have the B cells, and then you have the dendritic cells, and then they process them. So this is how, okay. So antigen presenting cells, what they do is that, so they will take up the antigen. This is the antigen. Suppose you consider this a macrophage, and this macrophage take up the antigens, okay, and these antigens will be present to the T cells, okay, and T cells will be, they'll have the receptors, T cell receptors will be there, okay. So this T cells, that is T lymphocytes or whatever it is, and so the T cells will have the receptor, and macrophage, what it does is that it takes up the antigens, and then these antigens will be processed and presented to the T cells. So the T cells can be of CD4 complex or CD8 complex. Okay, so then finally you will have the mature T cells, and then once they form the mature T cells, they can recognize the antigens and then produce the antibodies. So first thing is, before recognizing the antigens, as such, whenever an virus enters into the body, immediately antibodies will not be produced. So in order to produce the antibodies, so that the pathogen can be removed from the body, first that antigen has to be, okay, presented to the T cells. Okay, so how the antigens are presented is by macrophages or B cells, okay, and then dendritic cells. So these cells, they process the antigens and present to the T cells. Then T cells will become mature T cells, that is CD4 or CD8. Once they become the mature T cells, then production of antibodies will be there. So, and this whole process, okay, so this process, that is processing of antigen presenting cells, is regulated by human leukocyte antigen regions in the chromosome 6. Okay, so this is how the antigen will be presented to the T lymphocytes. Okay, and now coming to the here. Okay, so how you have the autoimmune disease, and in the type 1 diabetes, it is an autoimmune disease, we know that. So that means for beta cells, or okay, beta cells, we know that beta cells of pancreas, Langerhans, beta cells of Langerhans, we know that they release the insulin, they produce the insulin. So in type 1 diabetes, what happens is that beta cells will be considered as antigens, and antibodies will be produced, and these antibodies go and destruct the beta cells. Once if the beta cells are destructed, okay, then insulin will not be produced. There won't be any insulin at all. And if insulin is not there, then circulating, that is the plasma glucose levels will increase. Okay, hyperglycemia will happen to it will become hyperglycemia. So how this autoimmune disease will develop? So, and now we know that thymus, okay, so it will produce the thymus. In the thymus, what happens? So in the thymus, to produce the thymocytes, okay, that is T cells we call. And then in case of autoimmune disease, and antigen presenting cell, this is macrophage or whatever it may be, antigen presenting cell, in combination with the MHC, okay, MHC, that is major histocompatibility proteins. These are the proteins, major histocompatible proteins, in combination with the antigen presenting cells, okay, take up the antigen, okay, that is antigen here in case of diabetes, type 1 diabetes, antigen will be of insulin or proinsulin, okay, insulin or proinsulin. Insulin and proinsulin is recognized as antigen, and that and insulin and proinsulin, okay, will be present to the T lymphocytes. This is the T lymphocyte, and this is the antigen presenting cell, and in combination with the major histocompatibility, okay, tissue, and this one takes the insulin and present to the T lymphocyte receptor. Okay, so this can be insulin or proinsulin. Insulin, sometimes it can be insulin or proinsulin. So first here it will be of insulin, proinsulin will be present to the T lymphocytes as antigen by antigen presenting cell. Okay, and now in our own body, our own proinsulin will become an antigen that will be recognized an antigen by T lymphocytes. That is how it is done, because here antigen presenting cells, they present in proinsulin as antibody to as an antigen to the T lymphocytes. And once this processing happens, presenting happens, then there are two ways. One is negative selection and positive selection. Negative selection means this recognition will be destroyed, and positive selection means, so this recognition happens mature T cells, okay. So T cells, we know that, okay, immature T cells to mature T cells that we have discussed here, okay. Once recognition happens, antigen is recognized, and T cells will become mature T cells. Same way here, so the antigen presenting cell presents the proinsulin as an antigen to the T cell. Then through the positive mechanism, positive selection, then this will become mature T cell. This is central. Okay. Now what happened is that in thymus gland, what happened is that antigen presenting cell presented proinsulin as an antigen to the thymus. Then you have the matured T cells. Then they will come to the peripherally and into the circulation, then they can generate T4 cells, that is a periodic regulator, that is a CD4 cells or CD8 cells, okay, and then CD4 or CD8. So this T mature cells can be of CD4 or CD8. Then finally what happens is that here, okay, once it is recognized, okay, as insulin as a antigen, then this will stimulate the production of B cells, okay, antibodies, and these antibodies then go and attack the B, that is Langerhans cells, beta cells of that is Langerhans cells, okay, and this beta Langerhans cells will be destroyed, and once if they are destroyed, you will not have the production of insulin. So this is the pathway, okay, you should understand, this is the pathway how autoimmune disease will be generated, okay, in type 1 diabetes. It is an autoimmune disease. Then how this autoimmune disease happens? This autoimmune disease happens because our own insulin, okay, will be recognized as antigen, okay, own insulin will be recognized as insulin, that is as antigen. So now in order to do that, okay, so here in case of that is first what happens is that the insulin will be presented as antigen by antigen presenting cells to the T lymphocytes. Then they are immature, okay, immature, and they'll become mature T cells, and then they enter into the circulation, okay, enter into the circulation. Once they enter into the circulation, this all happens in the thymus, okay. So first, to develop autoimmune disease, this should happen in the thymus. So in the thymus, you have the macrophages. These macrophages present the insulin as an antigen to the thymocytes, okay, T cells, and then once if it is presented through the memory, whatever it is, and then that is a pro-insulin, mature T cells, and then once mature T cells you have, so you will have the CD4 cells or CD8 cells, okay, CD8 cells and CD4 cells, okay, CD4 or that is a regulatory, that part we are not going to do. This part only we are going to discuss. So CD4 cells and CD8 cells. So what they do is that, so they can present again, okay, they can be that is with the insulin coming from the beta cells or with the pro-insulin, okay, pro-insulin. And once you have the pro-insulin as or insulin as antigen, okay, and then this causes the stimulation of beta cells, okay, that is antibodies, B cells and antibodies, and these antibodies will go and try to destroy the beta cells of Langerhans. Once the beta cells of Langerhans, because we know that insulin is coming from beta cells of Langerhans, and then these antibodies will destroy the beta cells of Langerhans. This is how type 1 diabetes will be progressing. So type 1 diabetes, how it is progressed. First, antigen will be recognized. That antigen here it is that pro-insulin or insulin, and then the thymocytes, the T cells will become mature T cells, and mature T cells will be of CD4 and CD8, and then you have the recognition, that is a stimulation of beta cells, that is an production of antibodies. So this is how the autoimmune disease that is here in type 1 diabetes happens. Next one is that type 2 diabetes. So first we know we discussed that how type 1 diabetes happens. Type 1 diabetes, we know that beta cells will not be there. There is slow destruction of beta cells, that is which are producing the insulin. How means this is by our own immune system. Our own immune system will be destroying the beta cells. So that is how antibodies are produced, means, so this way here proinsulin will be recognized as antigen. Once proinsulin is recognized, mature T cells stimulate the antibodies production. This whole process is regulated by human leukocyte antigen. Okay, why insulin is presented as an antigen? Because you have the human leukocyte antigen. This human leukocyte antigen, this will regulate the presentation of insulin as an antigen. Once insulin is recognized as an antigen, then antibodies is produced and beta cells will be destroyed by antibodies. That is, next one is that, okay, then type 1 diabetes we can call as a non-insulin dependent, okay, and that is insulin dependent. Type 2 is non-insulin dependent, okay. And here, this is how the progression of type 2 diabetes happens. First, we know that one thing it is, we understood that. So the causes for type 2 diabetes, that is obesity, okay, obesity, or you have the lifestyle and increased age or bad diet. So now, first how the type 2 diabetes occurs. First, we should know the glucose transportation, how the glucose is taken up by the cell membrane, periplasmic membrane, how the glucose is transported. Once glucose from plasma into the cell. So once if it enters into the cell, glucose will be metabolized, okay, and energy will be produced. How cells will be taken up? We know type 2 diabetes, so that is increased glucose levels, plasma levels of glucose. That is because of the non-availability of insulin, or if even the insulin is available, but that available insulin is not sufficient to transport the glucose. We know that insulin is responsible for the cellular take-up of glucose. Okay, insulin, it will help in the cellular take-up of glucose. So type 2 diabetes, okay, we call it as a insulin dependent. Okay, that is non-insulin dependent. And first, before understanding that how type 2 diabetes happens, we first see that how glucose is taken up by your cell. So here, if you see that, okay, insulin on the cell membrane, you will have the insulin binding receptors. Okay, that is insulin receptors. This is an insulin receptor, and insulin binds to the insulin receptor. Okay, whenever, so that is when you take the food, and when you take the food, then in the food you have the carbohydrate, and these glucose molecules will be there. So these excessive glucose molecules, they trigger the release of insulin. Then insulin binds to insulin receptors. Okay, and insulin receptor, again, what it does is that it is having a substrates. Okay, insulin, this is outside the membrane and inside the membrane. So inside the membrane, that is insulin receptor, it is having certain receptors. They are called as a IRS receptor, insulin receptor substrates. Insulin receptor substrates. Okay, so once insulin binds to the insulin receptors, then this insulin receptor will be phosphorylated. And phosphorylation of insulin receptor in turn causes the binding of insulin receptor substrate. Okay, so insulin binds to insulin receptor, and this will be phosphorylated, and phosphorylation of insulin receptor and activates this insulin receptor substrates. Okay, insulin receptor substrate, especially this region, that is insulin receptor substrate, protein region 85. Okay, and that this you don't, okay, this and all you don't mind. So insulin receptor substrates will be activated. So activation of this insulin receptor substrates, what they do is that, okay, so they convert, okay, here phosphatidyl inositol diphosphate will be converted into phosphatidyl inositol triphosphate. So this conversion, okay, cellular conversion only, it is biphosphate to triphosphate. This conversion will be carried out by insulin receptor substrate. Okay, so here this conversion happens. Once this conversion happens, okay, so there are protein dependent kinases. Okay, one is protein dependent kinase 1, protein dependent kinase 2. So these two enzymes, they activate the AKT, that is a protein. So it is also called as protein kinase B. Protein kinase B. We have protein kinase C, okay, protein kinase A, and same way AKT, that is protein kinase B. Okay, so this is the process. Insulin binds to insulin receptors, and then once if it binds, the insulin receptors will be phosphorylated. We call it the autophosphorylation. And once if the autophosphorylated, then what happens is that you have the insulin receptor substrates binding. Insulin receptor substrates binding. Insulin receptor substrate, they bind to this, and then binding of this causes conversion of phosphatidyl inositol biphosphate, and then that will be converted into triphosphate. This will be converted into triphosphate, and this triphosphate activates, okay, PDK1, PDK2, and these two in turn activates protein kinase B. And activated protein kinase B, what it does, it involves in many functions. So one is adipogenesis, then glycogen synthesis, protein synthesis, and another mechanism is that glucose transport. So how this protein kinase B helps in the glucose transport by translocating the enzyme called as that is not transporter, that is GLUT4. GLUT4 you have here on the membrane. Okay, so you have here GLUT4. This is the glucose transporter. This is translocated, and so now glucose will be transported to the cytoplasm. So this whole process, okay, transport of glucose happens through the glucose transporter, and that glucose transporter activated by a protein kinase B. That protein kinase B also is called as AKT. So this activation happens through the protein dependent kinases. This is one, and because here this protein dependent kinase 2, it activates the serine protein, that is a serine protein 473, and whereas protein kinase 1, okay, it activates the phosphorylation. It causes the phosphorylation of threonine protein, that is amino acid, that is 308. So this also causes the phosphorylation, and this also causes the phosphorylation, but two different amino acids of protein kinase B. So protein kinase B will have the amino acids. Those amino acids are T308, and that is T308 means threonine, and S473 is serine. So these two amino acids of protein kinase B are phosphorylated by protein, that is a dependent kinase 2 and protein kinase dependent kinase 1. Once if it is activated, okay, so then the glucose will be transported. So this activation is done by these two protein dependent kinases. So that these two are activated by phosphatidyl inositol triphosphate. So this comes from biphosphate. So biphosphate is, this conversion is done by insulin receptor substrate. So this insulin receptor substrate, when it is activated, insulin receptor autophosphorylation. So when the insulin receptor autophosphorylation happens, once the insulin binds to the insulin receptor. So insulin binds to insulin receptor, and this will be phosphorylated, and phosphorylation converts, okay, that is brings the insulin receptor substrates, and these insulin receptors binding leads to conversion of biphosphate to triphosphate. This triphosphate activates protein dependent kinases 1 and 2, and then they activate the protein, that is protein kinase B, and this protein kinase B causes the translocation of glucose transporter 4 and okay into the membrane, and then glucose will be transported into the cytoplasm. There then you will have the glucose metabolism. So this is how glucose is transported. This is how glucose is transported. And so now here, sometimes what happens is that in type 2 diabetes, okay, non-insulin dependent, right? Yeah, what happens is that there will be insulin resistance. Even though sometimes this, okay, in the case of insulin receptor, what happens is these receptors may not be present, may be low in number, or sometimes and this insulin production will be less. So in those cases, what happens is that the cells, glucose will not be transported into the cell, and glucose will not be metabolized in the cell. So here, glucose in the plasma, you will have the elevated levels of glucose in the plasma. This is how type 2 diabetes develops. So glucose in type 2 diabetes, glucose will not be transported or are taken by the cells. Okay, that is because of the dysfunction of this glucose, that is insulin receptor. Sometimes insulin will be present, but it may not be sufficient to transport the glucose into the cell. Or sometimes what happens is that these receptors may be present, okay, but they are present in the low number, and that may not trigger the cascade reactions to transport the glucose into the cell. Okay, so this is how type 2 diabetes develops. So in type 2 diabetes, the glucose will not be transported into the cell. Okay, so this is how glucose is transported. This function will not happen. Transportation of glucose will not happen. So why it will not happen? Maybe sufficient insulin is not there, or the number of insulin receptors are less. Insulin receptors are less. So in those cases, so there won't be any sufficient insulin. Insulin will be there, but it will not be sufficient, or there won't be any receptors. Okay, these insulin receptors. In those two cases, so the glucose, this cascade of reactions will not be initiated, and then glucose will not be transported into the cell for the metabolism. So once glucose is not transported, it remains in the plasma itself, and you will have the type 2 diabetes. So 1 diabetes, in type 1 diabetes, yeah, our own insulin or proinsulin will be considered as an antigen, and once insulin and proinsulin is considered as an antigen, beta cells will be destroyed. Once beta cells are destroyed, you will not have the insulin. Okay. So this is how our type 1 autoimmune disease will be developed. And type 2, this is how the type 2 diabetes is developed. These are the molecular mechanisms how type 1 and type 2 diabetes is developed. So this is till today, this is enough, and next class we see the treatments of type 1 diabetes and type 2 diabetes.